Mike, we made it.
We made it.
Healthcare Headlines Live.
Right. So you said that this is a record-breaking crowd. And
Post-pandemic.
Post-pandemic, record-breaking crowd. And they say correlation isn't necessarily causation, but
coincidence?
I think having Healthcare Headlines Live might be part of the reason, at least.
It's definitely it.
Definitely part of it. So thank you all for being here, and it is nice to be able to kick off the annual benefits forum with our back and forth, and hopefully many of you have been able to check out one of our new episodes of either Healthcare Headlines or Benefits Bites. We also have the HR Benecast that we do every month, and it's hard to believe we've been doing the HR Benecast now for 10 years. So that was a big milestone this year, and we're just slowly but surely working our way up the charts when it comes to podcasts. So we typically do like to keep these episodes short. Today we'll go a little bit deeper because we have a lot of content that we want to make sure that we hit on today. And to get started, I've been in the health benefits space now for a little over 20 years, and I want, for those of you who have been in the space for that long as well, I'd like you to go back with me 20 years ago to a much simpler time. It was always sunshiny days, and it was nice. Rebates were like $5 a script if you even received them. The biggest formulary decision we had to worry about was, do we have Lipitor on our formulary, or Crestor, or Zocor? Specialty wasn't even a thing back then. And you go forward to the Affordable Care Act in 2009 and 2010, so a big federal legislative effort that we had to combat.
And it had its 16th birthday yesterday, Affordable Care Act.
Yeah. So we had that. We had time to implement that. In 2011, CVS introduced formulary exceptions or formulary exclusions for the first time, so that was a big change that we had to deal with. We said about the same time that specialty would be 50% of our total pharmacy spend, and at the time we thought, how in the world is that going to happen? And it did, and it's above that. And then we got to the introduction of biosimilars, and really the point is, as we make that arc, that all of these things happened individually to us in the marketplace, and they were each challenges or opportunities that we had to address, but we never had them hit us all at the same time like we have today. So a very dynamic marketplace out there. We have federal legislation, we have state legislation, we have biosimilars, we have new specialty drugs, we have AI, we have all kinds of new technology. So a lot of changes for plan sponsors and consultants to work through. And the one thing that I want everyone to know is that, here at Employers Health, we see our role as really a reassuring voice, a calming hand, a trusted partner to help navigate through these changes that are out in the marketplace. So with that, should we get started?
I think that sounds great.
All right, so let's start with the Consolidated Appropriations Act. There's a lot in there as it relates to pharmacy benefits managers. Let's let the folks know what the key parts of that are.
Big piece of legislation. It was the government spending bill that passed earlier in February this year. Lots of provisions impacting the Medicare marketplace, but also some provisions that were notable for commercial plan sponsors. And I like to think about it in three different buckets. The first requirement is that PBMs now must pass through 100% of rebates to plan sponsors. The second requirement is now that PBMs owe pretty comprehensive disclosures to plan sponsors about the specific spread pricing and compensation derived under their agreement. And then thirdly, there's a requirement that now plan sponsors must notify plan participants on an annual basis of these reporting requirements, the availability of this information, and that it can be provided upon request.
So three big pieces. Let's go through each of them and unpack those.
Yep, the devil's really in the details here. So whenever we think about the requirement of 100% pass-through of rebates, one of your first questions may be, are rebates defined in the legislation? And the answer is, no, they are not, but there is a pretty strong indication that it is a very expansive viewing of the term rebates, because PBMs and affiliated entities must pass through those rebate amounts. So those could also be rebate aggregators and group purchasing organizations, all fees, remunerations, and discounts from all of those entities. When it comes to the PBM reporting requirements, this is going to be a massive reporting requirement. So this is by drug and therapeutic class level, the amount reimbursed by the PBMs to pharmacies, the amount that the plan paid the PBM, the amount of spread derived from each of those drugs, as well as drug level rebate information. The plan sponsor specific reporting requirement cannot be ignored either. Now, plan sponsors will have to annually provide notice to participants of this information and make sure that they're aware that plan summary information is available.
Yeah. You know, we've been asking for drug level rebate information for years and years. And so I think that there's a real opportunity here if we can get that information. The benefit to plan sponsors is that we can make better decisions about, particularly for certain drugs, do we do more clinical management and try to change the drug mix, or do we take the rebate? And without the drug level rebate information, it's difficult sometimes to make that decision, and this should certainly help us perform that task a little bit better. You talked about the requirements. Are there any penalties for not complying?
There are civil monetary penalties in this law, so $10,000 per day where a party fails to provide required information. So remember, that penalty can be against the PBM for not providing to the plan, but also for the plan's inability to provide that information to participants. So it will be key to have this information readily available, and certainly that's something that the PBMs will help aggregate. There's also a $100,000 fine for each false statement that is disclosed or reported. But of course, there will likely be some safe harbors for innocent plan fiduciaries who reported information to plan participants that they didn't necessarily know was incorrect or false.
Yeah, so a lot of changes here. There's penalties for non-compliance. How about effective date? When do we expect this to take effect? And you talked about Department of Labor rules. When do we think that they'll issue those rules?
It takes effect 30 months from the date of enactment, so that'll take us to August of 2028, but it applies at plan renewal. So for most plans, for calendar year plans at least, this will take effect 1/1/2029. And you're exactly right. We have this piece of legislation that's really only a few paragraphs in total, but what are the details? That's what we'll receive from the Department of Labor. And the Department of Labor will release and issue those final implementing rules within 18 months is the deadline. So I would say that mid next year, we'll have a pretty good idea of what this is going to look like ahead of the requirements going into effect. Well, I think that's enough for the CAA there. Always a lot when it comes to a piece of federal legislation, but we'll keep you updated. Do you think that we should switch to the Federal Trade Commission proposed settlement?
I think that's a good place to go next, and maybe get us started by reminding everyone how this all got started.
Yeah, this all started in 2024. You'll recall that the FTC launched, they didn't even call it an investigation, it was a probe. So a preliminary investigation into the big three PBMs. And then as a result of that investigation, there was an administrative action filed by the Federal Trade Commission, and it really all had to do with insulin pricing. So it's very surprising now that as we come out of that administrative action, because it's not a lawsuit, it's an administrative action, we have this proposed settlement in which Express Scripts has agreed to major structural changes to its standard offering. Mike, what are some of the key provisions in these proposed changes?
Yeah, there's two types of changes in the proposed settlement, and one set of changes will impact the way that Express Scripts does business, will impact all plans. The other part and the other set of changes really are those that Express Scripts has to put into what the settlement defines as a standard offering. So it's something that Express Scripts will have to make available to all of its clients. Its clients can contract under different terms, but the caveat is if you do that, you have to sign off on an acknowledgement that you were made aware of the standard offering and that you chose to contract under a different set of terms. And so that is a template acknowledgement, so there's no going back to legal and having them soften the language. It is what it is. So let's talk about the big changes that will impact all deals, and maybe one of the biggest ones is the delinking of Express Scripts compensation from list drug prices. So today, all of the GPOs get a percentage of the list price as part of their compensation. And so part of this settlement is that Express Scripts in this case will delink, so take away its as a percentage of list price that inherently creates a conflict, right? More compensation for the PBM for higher list prices. So if you delink that, the idea is hopefully it will give more flexibility for prices to naturally come down. Also, we know that there are certain drugs where the manufacturer puts out both a low WAC product and a high WAC product, and it would stop Express Scripts from preferring the high list price drug. Disclosing all compensation to brokers and consultants. So for some employers, that may be standard practice, but for others, certainly it could be a surprise. Pay retail pharmacies on a cost-plus basis, and we'll talk more about this as we go through our discussion today, but certainly that is a big change from the traditional AWP minus some sort of discount. And then onshoring the Express Scripts' GPO, which is called Ascent, that is probably more of a political win than anything else, but currently that GPO is domiciled in Switzerland, and so part of the settlement is onshoring that back to the United States. So those are the changes that are going to affect the way that Express Scripts does business generally. In terms of a standard offering for clients, we're talking about applying the value of rebates at the point of sale. And so that's all about getting participants to share in the value of rebates. This one is interesting. I looked it up last night just to get a little more clarification, but no guarantees on the predetermined amount of compensation from rebates. So basically, stop offering rebate guarantees is in there. No spread pricing, the drug level product cost reporting that you talked about, and then including patient payments to Trump RX or other direct-to-consumer offerings in the member cost share accumulation. So deductibles and max out-of-pockets. So we'd have to figure out how we administratively include those in deductibles and max out-of-pockets. I think one of the big takeaways from all of this is that when you eliminate spread, when you cut down on the compensation from rebates, you're going to see more fees from the PBMs as we move forward that are specifically called out.
And I just have to get on my soapbox for a moment here, because many of those requirements that you just listed off, so the requirement to report broker compensation and as well as drug level reporting, those are now already required by federal law. So there's some stuff in there that's going to apply regardless, and now has become a part of federal law. So there'll be some harmonizing of those requirements as well. So we talked about the settlement with Express Scripts, the other two parties to the litigation, CVS and Optum. What are we hearing about those settlements?
Yeah, we know they're in the works. We know that there's an initial court hearing in the middle of June. So if there is a settlement, we would expect that it would occur prior to that date.
A few weeks ago, in one of the filings for the Express Scripts action, the FTC indicated that significant progress was being made with the other parties. And actually, last Friday, the Federal Trade Commission launched it's a healthcare investigation task force that will now look at other healthcare arrangements and will try to identify whether or not it's worth pursuing litigation in other areas in the healthcare industry. So definitely more to come out of Andrew Ferguson's Federal Trade Commission. Shall we move on to Trump RX and direct to consumer?
I thought you would never ask.
Oh, yes, Mike's favorite.
I can't believe we didn't lead with this.
Yep.
So talk about how patients are accessing Trump RX prices.
Absolutely. A couple of different ways. So Trump RX, the platform, is not actually buying and purchasing drugs and selling to consumers. In most cases, it is an aggregation of existing manufacturer websites. So you'll go onto the Trump RX platform. It will launch you to the manufacturer's website where then you can purchase the drug. In other cases, it will link you with a mail order pharmacy that is contracted with Trump RX to provide the medication at that pricing. And in other instances, it is a drug coupon that's available. So through a partnership with GoodRx, there's a coupon at the bottom of the screen, and it will list that Trump RX price where then you can present at the pharmacy.
Does it have the big golden eagle on it?
Oh, it sure does. Absolutely.
Excellent.
Check it out.
Excellent.
There are some issues, though, I will say. Something that was surprising about the Trump RX platform is that there is not a requirement for pharmacies to honor that negotiated price. So if you go to a pharmacy, present the Trump RX coupon, that may not be the price that you end up getting. And this falls back to many of the reimbursement issues that we see because you're supposed to be getting a coupon that has a certain price, but pharmacies are still buying and acquiring these drugs based off of the list price. So if they're going to operate at a loss, may not ultimately honor that price.
Right. They have to figure out how am I going to get reimbursed for the difference in what I'm buying it for versus the lower price that this coupon's offering it for. And I had posted when Lilly came out with its direct-to-employer announcement, I had posted on LinkedIn, and that's a shameless plug. If you don't follow me on LinkedIn, you can.
That's the first one so far.
First shameless plug. Wow. But certainly, I posted just lower the list price. Like, we don't need to send patients to all these different places because we can't get a lower list price that's more reflective of what you actually want to sell the drug for within the benefit plan. So I think that with the direct-to-consumer stuff, we are seeing some impact on list prices. Novo Nordisk had its announcement in terms of lowering the price of Ozempic and Wegovy, which is a welcome news, and we are waiting to see whether Lilly follows suit with its GLP-1s, and we know that there's an oral version that is slated to get FDA approval sometime around April 11th. We know that the next Lilly earnings call is April 30th, and so hopefully sometime in the month of April, we'll get a little more clarity in terms of where we're heading with list prices of these GLP-1 drugs that are driving most of your budget. It's also driving a big portion of the rebates that you're getting back. And so we expect that it'll have a big impact in terms of what we're paying up front and what we're getting on the back end in terms of rebates.
Well, great. And you know what time of the year it is? It's March Madness, and that has to do with basketball, I'm told, but it also has to do with state legislation. There's lots going on this year, as in pretty much every year that we've talked about this so far since 2019.
We should have had some jock jams going for this.
Yeah, right. That's right. Trying to add some music here and there, but there's this thing called copyright infringement, so we're trying to avoid that as well.
This is what you get when you have a lawyer as your co-host, yeah.
State legislation, so I mentioned the March Madness component just because many states do adjourn in the months of April and May leading into June. So we're coming up against some statutory deadlines in certain states. So legislation, if it is going to pass, is going to start moving very rapidly. We're continuing to see states pass or states introduce legislation that would mandate minimum reimbursement levels to pharmacies within the state. It depends on how broadly this applies, whether it's certain types of pharmacies or all pharmacies in the state. Many times that's accompanied by a minimum dispensing fee that also must be paid. These laws are increasingly broad in that they are applying to ERISA plan sponsors as well. Sometimes the legislation is vague and it doesn't address specific entities that it applies to. That's a hint that they're going to enforce that in a very broad manner. But whenever it comes to major pieces of legislation that may require minimum reimbursements to pharmacies, but also may have some of these anti-steering components, so not being able to steer towards a narrower in-network set of pharmacies, not being able to offer participants an incentive to fill at a mail order pharmacy, whether that be by getting a higher day's supply or paying a lower copay for filling at that mail order pharmacy. And there's been a lot of litigation on this front as well. And federal courts are routinely finding, as well as the Supreme Court, that when it comes to these reimbursement laws across the states, those are going to apply to ERISA plan sponsors. So regardless of what type of plan sponsors you are, unless there's a specific exemption in that law, that minimum reimbursement law is going to apply because they classify that as cost regulation. But whenever we get to those parts of laws that truly do dictate plan design, so what type of network you can set up, what type of copay structure the plan may have, that is the piece that courts are routinely finding to be preempted by ERISA. So not applicable to ERISA plans so that you don't have to address state-specific requirements across the many states you may operate in. The problem is there's not been a nationally binding ruling on this from the Supreme Court. So that may contribute to the patchwork of legislation that you may be hearing about from Employers Health as well as your PBM vendor on calls.
So you talked about the themes that we're seeing. I won't ask you, and we don't have time to walk through all of the individual state laws, but maybe highlight just a couple of them.
Yes, because we have a lot of Ohio employers in the room today, and I think that this is a good example of what we see in other states. I did want to highlight Ohio House Bill 192, which is a bill that says that any willing pharmacy must be admitted to a plan sponsor's network. Those pharmacies need to be treated equally, so no ability to distinguish between in and out of network pharmacies. It also has that minimum reimbursement provision, so pharmacies will have to be reimbursed at their actual acquisition cost for the drug. And also a minimum dispensing fee will apply that is tied to the state Medicaid survey. So that's currently around $12. Something that's important to call out whenever you do see these state mandated pricing laws, all of those claims are excluded from the contractual guarantees of your PBM contract. And what's especially interesting about this particular Ohio piece, and we see this across many other states as well, it's not narrowly tailored. So this reimbursement and a dispensing fee would apply to all pharmacies in the state. So it's not just the independent pharmacies that they're talking about. The same would apply at Kroger, Walmart, CVS, any pharmacy that you fill at.
And who do you think will pay for that $12 dispensing fee?
It's not the PBM like the legislators think. No.
Patients,
it's plans, it's patients in the pre-deductible phase. So costs will certainly rise. And that applies for mail order, specialty, and retail as well.
Yeah. I think one of the disappointing things about state legislation is they're all couched as lowering drug prices. And I don't know that any of them lower drug prices. Mm-hmm. Most of them raise drug reimbursements to the retail pharmacies and, in effect, will raise the prices to patients and to plans. Yep. So just a mismatch in terms of what we're trying to accomplish and what the public policy is coming out with. So let's move on to ERISA fiduciary litigation. We could spend the whole conference talking about this topic,
Truly.
but let's give an update on developments in key cases this month, and we'll start with the Wells Fargo dismissal.
We originally weren't even going to make this a huge portion of this talk, but there were two major dismissals that occurred really in just the last 3 weeks. So thought it was worth mentioning, especially here. So the Wells Fargo case was dismissed, and these findings were similar to what we've seen in many of the other dismissals of the Johnson & Johnson case as well. What courts are finding routinely is that the plan overpaying for certain specialty generic medication, plan participants are not able to prove that as a result of those overpayments, plan participant premiums were higher. They contrasted PBM and health deals from 401k benefits. They said in the 401k fee litigation that we saw decades ago, you were able to quantify the actual benefits lost. Whereas in this case, in defined benefit plans, participants are receiving all benefits due to them under the plan. So how do you quantify an actual financial injury here?
Go ahead.
Yep. Well, and then I was just going to say the other piece here, the J.P. Morgan Chase dismissal as well.
Yeah, it was like a week later.
A week, yes.
They partially dismissed the J.P. Morgan Chase case.
Yes, a partial dismissal. And what I think is an important call out here for plan sponsors is that the court distinguished between plan design decisions and fiduciary decisions. So it threw out the fiduciary breach claims because it said whenever a plan sponsor is looking at whether or not to have traditional or pass-through pricing, whenever they're wondering, looking into having a specialty carve-out vendor, their formulary design, they said those are plan design decisions. They're not fiduciary decisions. They're not subject to the fiduciary standard. It's a way of recognizing that employers also have a business interest in designing and forming a benefit plan. So the pieces then that remained, the court kept some prohibited transaction claims on the table. I see this as, people are wondering, does that mean that JP Morgan Chase did something wrong? Doesn't necessarily mean that at all. What now happens from a legal posture of the case is that the employer has the ability to show, I made reasonable decisions. This was a reasonable contract for necessary services under the plan, and I paid no more than reasonable compensation. So this is why we talk about to employers, on every call it seems I'm having a call explaining this, you need to be able to point to a very sound decision-making process that is well documented. Whenever you are selecting vendors in that ongoing monitoring of plan performance and your vendor's performance, you want to be able to point to a strong file of evidence that shows that you made reasonable decisions. I think that the transparency rules and regulations that continue to pass, it's forcing a lot of this information out into the open. And so it'll now be an interesting time where plan sponsors have to look to that information. How do they use it? And how does it inform their decision-making process?
Yeah, the transparency will certainly help, but it doesn't necessarily do the job for the employer or the plan sponsor, so they need to still do it.
And reasonable, ERISA doesn't require that you always choose the lowest cost vendor. It requires you to make a reasonable decision. So cost is but one of many factors that it may take for you to consider what vendors that you work with. So,
excellent. Well, we asked through our promotion of this, we asked for individuals, whether you were going to be here or not, to submit some questions, and I know we got a few of them.
We
so
did.
Why don't shall we go to those questions?
Well, what's the point of a live podcast if we don't do some Q&A? Mike, first one for you. This listener asked, I'm used to big rebate guarantee increases. What should I expect from market checks in 2027?
Yeah, I think market checks in 2027, it's not going to be the same as you're used to seeing. We talked about the cost plus reimbursement mandates, and so discounts historically haven't necessarily gone up substantially over time, and I wouldn't expect, at least on the retail side, to see big changes in the discounts going forward. On the rebate side, we talked about GLP-1s, so if Lilly follows Novo's lead and lowers its price, I mean, from a diabetes perspective, you're talking about $10 to $13 per member per month in less upfront costs, but less rebates. And if you also cover weight loss, you're talking about anywhere from $20 to $25 per member per month in lower upfront costs and lower rebates on the back end. So in terms of what you're used to seeing in terms of big rebate guarantees jumping out off the page from year to year, I would not expect that for 2027. The only way that that will happen is if a PBM loads up the rebates with a bunch of drugs that have already lowered their price, and they take rebate credit on all of those medications. And our approach is there are plenty of games being played out in the marketplace. Being a part of Employers Health doesn't need to add more games to that. We want to cut through the noise, provide a reliable contract. So that's what we'll aim to do as part of our 2027 market check. All right, Madison. Question for you. Is there overlap between the new federal PBM disclosure requirements and the RxDC reporting? How are they related?
Ooh, this was a good one. They're not related, or they may seem to be. So if you'll recall, RxDC reporting, that is due annually by June 1st. There's some required reporting from the plan, as well as the PBM that needs reported to HHS through a secure portal. The purpose of RxDC reporting is really looking at rebates, highly rebatable drugs under the plan, and whether or not those rebates increased or had any type of effect on participant premiums that are paid. So it all has to do with how are rebates tied to participant premiums. That information has been historically criticized, just given that that information is reported at the state and market segment level. So it's not each individual plan sponsor getting insight into their actual plan data. It's all similarly sized self-insured employers in the state of Arkansas are lumped together and reported by the PBM. What is interesting about the CAA of 2026 is that that is actually your plan data, and it's reported directly to you from the PBM. So one would think, and one would hope, if the reporting requirements are clear enough, that this can be really actionable, helpful data that is specific to your plan. Obviously, it'll come with a 100-plus page instruction booklet, as the RxDC reporting did. So probably some future headaches to parse through that information, but if they can get it right, it can be useful information.
As a sarcastic member of this team, I think it's only appropriate to say that what I think I heard you say was it added a lot of administrative burden, added administrative cost,
Yes.
Hasn't been useful.
Yes,
Okay.
and I think anytime that is the key piece. If you're asking for information from the PBM, don't put the requirement on the plan sponsor to then get the information from the PBM. This part is helpful because it's PBM reported directly to the plan sponsor. But yes.
Excellent.
My question for you, let's do this one. Opportunities for plan sponsors as we look to 2027. Where are the biggest opportunities that you see?
Yeah, I'll break it out into both non-specialty and specialty. So on the non-specialty side, we talked about GLP-1s lowering their price, so that should have a good impact, at least from a cash flow perspective and a participant cost share perspective. We have Farxiga going generic this year, so that is typically in your top 25 drug spend, so hopefully there'll be some opportunities there. I know the clinical team is already starting to look at that. Weight loss decisions, so do you cover, do you not cover? And I know that our colleagues will have a slide a little later on showing the difference in per member per month and trend. It's quite a noticeable difference when you cover weight loss versus not. We're doing some work around prescriber outreach, so typically we think of prior authorization, step therapy, those types of claim adjudication edits that we put into plans. but also looking at how can we reach out to prescribers and get more information in their hands to help them better serve their patients. And then the Employers Health Custom Clinical Edits. So these edits have been around for a long time. They typically provide some early opportunities for savings aimed at getting low-value, high-priced drugs out of your plan spend, and typically between 1% to 3% of pharmacy costs that we're able to get out in terms of folks participating in that. And we have over 90% of our clients that use at least one of those custom clinical programs. On the Stelara side, or on the specialty side, I jumped the gun there. On the specialty side, we have the Stelara biosimilar for our CVS clients that we are implementing on 4/1. We have, I've heard 92%, I've heard 95% in terms of the number of or percentage of clients that are putting that in place. So again, a unique benefit to our clients. Also looking at the dermatological space, so a lot of dollars being spent on dermatologicals, and with some of the new biosimilars, are there opportunities to do step therapy in those classes? I think it's a good chance to remind folks that if you wanted to do specialty PA carve-out, or you wanted to do full specialty carve-out, we do have clients that do that today under our programs. And so I think the big takeaway there is you have the flexibility to do that inside of your current arrangement with Employers Health. Prudent RX, so that's the CVS version, but certainly all PBMs have some sort of copay assistance program. Those continue, at least on the specialty side, to drive upwards of $6, $7 per member per month in savings. And so who knows, with all these price changes and new legislative requirements, what the future of those types of programs hold. But certainly as it exists today, those continue to provide a good amount of savings for clients. So non-specialty, specialty, lots of opportunities out there, and certainly our team is here to help parse through which ones might make the most sense for your specific plan. All right, Madison, the question was, wasn't there supposed to be a federal directive on copay accumulators and adjustment programs? Have there been any developments?
Yes, there was supposed to be a federal directive. So many of you may recall in early 2023, a DC federal district court invalidated the federal rule that allowed copay accumulator programs. So this was the rule that gave employers the discretion to choose how they counted manufacturer assistance. So whether it was included or excluded from a deductible and max out of pocket. Recognizing the widespread disruption that this court ruling would have on the marketplace, the then Biden administration entered a period of non-enforcement of this court ruling. So maintaining the status quo for plans, while the federal government then had the opportunity to rewrite a drafted rule that could be very specific about whether or not this was allowed. We still don't have this rule. Here we are 3 years later, and it wasn't included in the proposed rulemaking for 2027. So until this point, earliest we could hope for is a rule in 2028. But for the time being, the status quo has remained for plan sponsors as the government is in a non-enforcement policy of that rule. Question for you, Mike. A lot has been made about what's called a modular PBM. What do you think about them?
Well, breaking news on Healthcare Headlines Live. We need a sound effect for that. Dun, dun, dun.
Here we go.
So we are working, we're not ready to formally announce it yet, but we are working on putting the finishing touches on a modular PBM for Employers Health. And I can share what some of our learnings have been through this process. And the big one is don't try to drink the ocean. Keep it simple. So finding a core PBM, claims administrator, customer service, website, mobile app, all of those types of things. Find a core PBM to serve as the foundation for it, and we'll be announcing a fourth option here. And then finding opportunities in the market where it makes sense. So we're looking for mail order generics, specialty generics. Those are definitely areas that came up in the fiduciary lawsuits. Biosimilars, bringing biosimilars to the plan quicker, and obviously there's opportunities to do it at a cheaper price if you're able to get patients where they need to be in the marketplace. So what we know is that we need to make sure that we can connect patients with these opportunities. It has to be financially viable, and it needs to be a great experience, because we know that plan sponsors aren't going to accept a subpar experience for participants. So what it can't be is just a bunch of point solutions that you loosely tie together. That we know will not work. So we are in the process, like I said, of putting the finishing touches on this. I think a lot of the modular components of this, and I already talked about some of them in terms of specialty PA and specialty carve-out, those types of things will be able to fit on all the different PBM options that we have available.
Yeah. Related question, do you ever truly get away from the big PBMs in this market? It seems even when employers split up their PBM responsibilities, they end up using one or more of the big three.
Yeah, so Sam loves the line I use, which is it's not if you're going to use the big three, it's how you're going to use the big three. And I think whether it's looking at the GPOs that the big three have, a lot of mid-market PBMs utilize those GPOs for rebate contracting today, some for retail contracting, specialty pharmacies, so the big three all own a very large specialty pharmacy. So when you think of limited distribution drugs, even if we're looking at a specialty carve-out vendor that can fill 60 to 70% of the specialty drugs. So there's always LDDs that you're going to have to find access for, and so having them as a wrap network. So I don't know that, whether it's through the GPOs or through the specialty pharmacy, I don't know that you ever get away from using the big three GPO or big three PBMs, and it's because at the end of the day, the fact of the matter is they have a lot of value out in the marketplace, and I think regardless of what happens here, they're going to continue to have a lot of value. And so how do you appropriately tap into it so that your plan and your participants can get some of that value?
All right, shall we open it up to our live audience?
I think so. We have, 5 minutes
We
left?
have 5 minutes. If you have a question, please raise your hand or stand up, and our mic runners will come to you.
And if it's a hard question, make sure
Give it to Mike.
Make sure it's legal in nature, and ask Madison. Oh. And we can't see you, so...
Yeah, we can't see. Oh, I see a point. Someone's pointing.
So what you talked about participation in the rebate by the member. What does that look like? A $4,000 drug, they pay $100 at the pharmacy. What does rebate participation look like for something like that?
Yeah, so what it looks like is the traditional point of sale rebate. So if you had a $4,000 drug that had a $2,000 rebate on it, the member's cost share would be based on the net price of $2,000 versus the way it is today, where they're paying member cost share based on a $4,000 discounted price. Does that answer? Is that what you're looking for?
A set copay of $100 for that class of drug.
Yeah, then it doesn't matter. If you have a $100 flat copay, participants will continue to pay $100 unless the net cost of the drug is less than that flat dollar copay.
Okay.
Others?
All right, Mike, I'm moving on to one from our question submission. Will we ever get completely away from rebates?
Yeah. How much time do we have? 2
Exasperation.
minutes left?
Yeah, you have 2 minutes.
Well, I think the short answer is not anytime soon. So I think the mechanism of rebates as a way for PBMs on behalf of plan sponsors to negotiate additional discounts off the price of drugs is something important. And it was set up that way. It was set up in the way that it is, really to avoid some of the price discrimination lawsuits were around in the late 90s. And so there were settlements. They said you can't discriminate except for plans that are able to significantly move market share. You can give them additional discounts. And that's what a formulary is aimed to do. And that's what rebates are meant to reward, is the ability to move market share. It's also worth noting that the federal government, or the state governments and the federal government through Medicaid also get rebates. And so until we're willing to change the overall dynamic of how drug pricing works in the country, I don't think we're ever going to get away totally from those types of rebates.
Good job. Just over a minute.
Yeah.
Well, and with that, folks, thank you so much for listening to our discussion. If you have any questions for us, please feel free to find us during the breaks. We will be around. Thank you, Mike. Healthcare
Yeah.
Headlines Live. That's a wrap.
That's a wrap. Thank you, Madison.